Alrighty. Good morning, everyone. Hopefully, everyone can hear me. Um, this session is being recorded. Um, everyone should be, no one should be muted, so you can ask any question. I'm Dr. Russell Brown, psychiatrist and medical director at Avinia Behavioral Management. We are a mental health healthcare staffing company. We source psychiatrists, MPs, and PAs. As part of my collaborator and supervision role, um, I need to um, provide medical education, and we do this by case study presentations. The resources we use are psychiatric case studies for advanced practice, first edition by Prendergast and Jackman. Case File Psychiatry, sixth edition by Toy and Clayman. Adult Psychiatry Case Vignettes, second edition by Tavakoli and Sabor. That's Tavakoli dash SBOUR. And the fourth resource that we use um, is Child and Adolescent Psychiatry Clinical Cases First Edition by Amador. That's Amador. The case that we'll be discussing this morning is incarcerated with substance use problems. So let me go ahead and dive into the case. I will be stopping every now and then to allow people to ask questions. And you can go ahead, since no one's muted, you can just go ahead and speak out, and everyone can hear what your question is, and I can address it. We let one more person into the meeting. Alrighty. Identification. The patient's a 37-year-old single Caucasian incarcerated male. The patient was referred by his social worker that was assigned to his care. The chief complaint is I can't handle how I feel. I am on the verge of exploding at every minute. History chief complaint the patient was sent to jail due to a charge of driving while um, ability was impaired, DWI, um, specifically by alcohol, as well as resisting arrest and spitting on an officer. He has been in jail for the past month. Um, and This is his first visit with a mental health provider for medication management since coming to jail. He states that he started drinking socially at the age of 16. However, over the past few years, he's been drinking excessively to mask all the rage that he has inside. He stated that he knew he had a problem with alcohol about a year and a half ago when he received his first charge of driving under the influence of alcohol. His license was suspended, however, and he states that he drove with a suspended license to get to work as a construction worker. He states, I needed to get to work to pay my rent, so I figured I could get away with it. He states that he received a second DUI. Um, that He states that when he received a second DUI, he soon lost his job and began drinking more heavily. He states he needed more and more alcohol to quiet his mind and that he began drinking early in the morning to just feel normal. He states that he went to rehab once about 8 months ago, then abstained from alcohol for about 6 months after he completed a 28-day program. He began drinking about 2 months ago. He states that while he is was not drinking, or when he is not drinking, he felt extreme anger and agitation, often getting into fights with his landlord and other neighbors, which he feels led him back to drinking. So he seems to, and during his abstinence, he still has these problems with this anger and agitation. Um, Currently, the patient states that he feels angry all the time. I feel like I'm going to kill someone or freak out, quote unquote. He's gotten into multiple fights with other inmates in the jail and has been seen crying or shouting out in his cell by numerous correctional officers. He was seen by the social worker yesterday who referred him for a psychiatric assessment. He states that he was taking medications in the past, um, prescribed in jail, but they made him feel worse, so he stopped taking them and started drinking again. He doesn't recall the name of the medication he was given, and he did not continue them once he left the jail at that time. The patient reports feeling sad for the past month, angry, has difficulty concentrating, poor sleep. He sleeps about 3 to 4 hours every night, and he has a fluctuating appetite. He feels keyed up and on edge constantly. The patient denies a clear history of elevated mood for 2 weeks or more, but does report irritability, anger, and rage um, often. He states he has moods, ups and downs, and impulsivity and unpredictable behavior such as fighting and intimidation toward his girlfriend. He reports a history of intrusive thoughts, recalling his father's death and his father's physical abuse toward his mother. However, he states that this only occurred once or twice um, in the past 5 years. Past psychiatric history. Um, the patient denies any past psychiatric hospitalizations. He denies ever seeing a therapist. He saw a psychiatrist through his rehab facility for the first time this year, and he was prescribed Prozac, which he states made him feel worse and more irritable. He denies any history of suicide attempts. Um, Patient does not have any current outpatient psychiatric provider. So, does anybody at this point? I'm going to stop. Does anybody have any questions about the history of present illness or past psychiatric history? It looks like this guy has an alcohol issue, and when he's not drinking, he still has some moodiness. And it looks like when he was placed on Prozac, it made him feel worse and more irritable. So that kind of gives us an idea what what some of the possible diagnoses are. Um, Anybody have any thoughts or feelings that they want to share at this point in the case? All right, I will proceed. And once again, I hope everybody is able to hear me. Um, all right, medical history. Patient denies any allergies to any medications, foods, or environmental factors. Um, Patient denies any major medical or surgical illnesses. The patient reports multiple concussions from fighting over the years. Review systems. Um, Constitutional is negative, HEENT negative, eyes negative, respiratory negative, cardiovascular is negative, GI negative for any abdominal pain, endocrine negative, GU negative, musculoskeletal is negative, um, skin negative, allergy, immunologic negative, neurologic negative, hematologic negative. Psychiatric behavioral is positive for some sleep disturbance, positive for anger and irritability, positive for some symptoms of depression, negative for anxiety, and negative for psychosis. Uh, History of drug or alcohol abuse. The patient endorses drinking alcohol socially since the age of 16. He states he began abusing alcohol at the age of 27 and currently refers to himself as an alcoholic. He has been to rehab once earlier this year and completed a 28-day program. The patient's last drink was the day he came to jail about a month ago. Patient reports past cocaine use over 1 year ago Patient reports intermittent cannabis use since the age of 13, but Stacy doesn't really like it. His last reported use of cannabis was about 6 months ago. Family history: the patient's mother is alive with no pertinent uh, health history. She lives nearby with her boyfriend. The patient states that his father died at the age of 45 due to colon cancer. He states that his father was an alcoholic. The patient has one brother who is 40, and he has been incarcerated multiple times and uses hard drugs. The patient also has a sister who's 35 years old and lives nearby with her son and her husband. She has asthma and a rare blood disorder, unknown type, as well as a history of anxiety. Uh, does anybody have any questions thus far about the medical history, review of systems, history of drug or alcohol abuse, or the family history? Any questions, thoughts, ideas of how this may be shaping what you're thinking the diagnosis could be? All righty. Well, I will keep moving on. Um, Personal history, perinatal. The patient's mother was 17 when she became pregnant with the patient. She did not use drugs or alcohol during or before the pregnancy and received adequate prenatal care. The patient believes he was a full term vaginal birth. The patient states that his father was an alcoholic and that his mother was once pushed by him during her pregnancy with the patient. The patient states he believes he was bottle fed but is unsure. Childhood: the patient states his childhood was normal and he dealt with usual childhood experiences. He does endorse a few adverse childhood experiences, but denies that they were symbolic uh, um, or pertinent to his identity now. He saw his father using alcohol and occasionally using drugs in the house. When he was 6, he witnessed his father being arrested for a domestic complaint when his mother called the police after his father held her against the wall by her throat. Um, the uh, the the He states that his father never physically assaulted his mother again in front of him. However, he states that they also did not speak much to each other after that event. The patient wet the bed once or twice when he was 11 years old. He had some friends growing up, but not many. He mainly hung out with his brother or stayed to himself. Um, um, he tried marijuana once or twice when he was 13 years old. He did poorly in school. He was in normal classes except for reading. He never really enjoyed school and often would try to get out of it by telling his mother he did not feel well. Adolescence: his father was verbally abusive toward him and his siblings. His father took his anger out on the patient. He would yell at him, push him, threaten him. The patient quit school in the 10th grade after his father died. He began working in construction with his uncle to help support the family. Um, his first time in juvenile detention was at the age of 15 um, and was due to stealing from a local department store. Adulthood: the patient received his GED while in jail when he was 24 during his fifth incarceration. His previous incarcerations were all for fighting or petty larceny. Um, um, he has a girlfriend for the past 9 years whom he lives with sometimes. Their relationship is often volatile.
Exceptional mental health assistance here.
Um, um, she has been to jail a few times, once for not abiding a restraining order that he had against her. The patient denies being religious or having any specific cultural identity. The patient denies any history of any military duty. Let's go on to the trauma abuse history. The patient describes an abusive relationship with his father. He states he also once was touched by a male family member friend who was asked to babysit a few times. The patient states that this babysitter touched his penis and told the patient not to, and told the patient to touch him back, but that his sister was calling, so he got out of it. Um, he states that this only happened once, and that as an adult, he saw the babysitter when they were both incarcerated in jail at the same time, and that he punched him in the stomach. He denies ever receiving therapy or telling anyone about this incident of sexual abuse. All righty. Before I go on to the mental status exam, does anyone have any questions about all the history on this patient that was presented? All righty, we'll go on to the mental status exam. Appearance: the patient has facial hair, good grooming and hygiene, and is wearing a blue jail jumper. Behavior and psychomotor activity: the gait is normal. There's some motor agitation with his legs shaking throughout the interview. Consciousness: the patient's alert but distracted at times. Orientation: the patient's oriented to person, place, and time. Memory: the patient has good memory retention, um, both immediate and 5 minutes later. His concentration: he's able to spell the word world forward and backward without any issue. He has difficulty with counting backwards from 100 in serial threes. The patient refused to continue after two attempts. The patient looked around at a clock and behind him when there were noises in the clinic. Visual spatial ability was not assessed. As far as abstract thought, he displays concrete thinking. Intellectual functioning is average. Speech and language. Um, there is some spontaneous speech. He mostly responds to questions. Uh, there's no articulation error noted. His speech is basically normal rate, rhythm, and volume. Perceptions: the patient denies any hallucinations, paranoid ideations. Thoughts and processes: these are linear and goal directed. Thought content, thought content. He voices hostility toward the others in the jail. Suicidality or homicidality: he denies any suicidal ideation, denies any homicidal ideation, but states, "I could kill someone, but I won't." Um, Mood is angry and irritable. Affect is constricted but redirectable and congruent to mood. Um, Impulse control is poor. Judgment, insight, and reliability is the judgment is fair. His insight is limited. His reliability is fair. So there we have it. We have the history and the mental status. Um, Anybody have any questions or thoughts about his history or mental status examination? All right. But we'll go on to formulating the diagnosis. So the question here is, which diagnosis or diagnoses should be considered? The author here has two: alcohol use disorder severe and unspecified bipolar or related disorder. So let's review the diagnostic criteria for the alcohol use disorder severe. Um, um, Diagnostic criteria is problematic pattern of alcohol use leading to clinically significant impairment or distress is manifested by at least two of the following and all occurring within a 12-month period. One, alcohol is often taken in larger amounts or over a longer period than was intended. Two, there's a persistent desire unsuccessful efforts to cut down and control the alcohol use. Three, a great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. Four, there's a craving or strong desire or urge to use alcohol. Five, there's recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. Six, continued alcohol use, despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. Seven, important social, occupational, or recreational activities are given up or reduced because of alcohol use. Eight, recurrent alcohol use in situations in which it is physically hazardous. Nine, alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the alcohol. 10, tolerance, and the tolerance is defined by either the following: one, a need for markedly increased amounts of alcohol to achieve intoxication or the desired effects, or two, a markedly diminished effect with the continued use of the same amount of alcohol. And 11, a withdrawal is manifested by one or by either of the following: one, the characteristic withdrawal syndrome for alcohol, um, and two, alcohol or a closely related substance such as a benzodiazepine is needed to be taken to relieve or avoid any of the withdrawal symptoms. So, um, as far as the rationale for this diagnosis, the patient has a problematic pattern of alcohol use that has led to clinically significant impairment, as evidenced by the need for him to take larger amounts over time, him attempting to stop the alcohol use by going to rehab, and having a strong urge to use alcohol again, which is his relapsing, and a persistent use despite his contributing to multiple incarcerations, a recurrent use resulting in failure to maintain employment, and use in physically hazardous situations such as driving under the influence. Because the use meets at least six of the diagnostic criteria, the diagnosis of alcohol use disorder and severe is applicable. Um, uh, does everyone? It's obvious that he has a diagnosis. Does anyone have any issue with the diagnosis or questions about it?
No.
All right. Which other diagnosis should be considered? The author here has a secondary diagnosis, which is unspecified bipolar disorder. Um, And this category applies to the presentations in which symptoms characteristic of bipolar that cause clinically significant distress or impairment in social, occupational, and other areas of functioning predominate, but do not meet the full criteria for any disorders of the bipolar or related disorders diagnostic class. This unspecified bipolar and related disorder categories used in situations in which the clinician chooses not to specify the reason that the criteria are not met for a specific bipolar or related disorder, and includes presentations in which there's just insufficient information to make a more specific diagnosis, such as when you're in an emergency room setting and you just don't have time to or elucidate all of the symptoms that may constitute a bipolar diagnosis. So, and what is the rationale for this unspecified bipolar disorder diagnosis? The patient repeatedly describes feeling like uh, like he's going to explode. Said he drinks to mask all the rage that I have inside. Um, he's had extreme anger and agitation, often getting into fights with his landlord and other neighbors. Um, Even after being abstinent from alcohol for 6 months in the past, he continues to experience these feelings. So this anger is not substance abuse related. It occurs outside of his alcohol use. Um, there's limited information to identify a clear pattern of these symptoms. The symptoms he describes do not meet the full criteria for bipolar disorder because he does not describe depressive episodes. Yet there's a strong mood component to his presentation. Therefore, the diagnosis of unspecified bipolar and related disorder will be used. Um, what does everybody feel about this unspecified bipolar disorder? The only thing that, oh, go ahead. Someone's about to say something. In my mind, the only thing that really kind of hangs a hat is he was on Prozac, I think, for a while. And he said the Prozac made him feel a little, some kind of way. Maybe that could be used diagnostically to say that the Prozac may have been getting him to a hypomanic or a manic state that increases irritability, and he may have a bipolar diathesis. So that's one consideration supporting this diagnosis. Uh, we'll go on to the differential in a minute, but in my mind, I'm thinking that this guy may just have a major a depressive disorder. It could be major depressive disorder. It could be persistent, or what we call dysthymia, persistent depressive disorder, and his irritability or anger may be a manifestation of that. But it is intense, so it could be other things too. Intermittent explosive disorder, and we'll talk about these in a minute. But the key thing is that with when he's off the alcohol, he's still angry to the point of getting into fights and then needing the alcohol to kind of help manage his mood. So it looks like he has either some kind of mood disorder or maybe he has intermittent explosive disorder. Uh, and the only medication trial he's had has been some antidepressants, one of which was Prozac. And he stated it made him feel a little funny. I don't know exactly what that means, but we just got to use all of that, um, to help us, all of those responses, uh, to help us kind of formulate what the secondary diagnosis is above and beyond the alcohol use. Does Before I get to the actual differential diagnoses, does anyone have any ideas of what other possibilities there could be based upon the history and the examination? All righty. Well, I'll move on to the differential diagnosis. We have several of them here: post traumatic stress disorder, antisocial personality disorder, unspecified attention deficit hyperactivity disorder, mild neurocognitive disorder due to TBI, intermittent explosive disorder, which I talked about earlier. Um, and I'll go into each one of these. Let's look at the PTSD diagnosis as a possibility. Uh, this patient has a long history of trauma, including his childhood experiences of seeing his mother abused in the home, his father being taken to jail by the police, sexual abuse by a male babysitter, as well as physical and emotional abuse by his dad. Um, Although he denies most symptoms of post traumatic stress disorder, he does report a history of re experiencing the trauma. PSD symptoms can surface over time and should be screened for at various time points. At the time of this evaluation, though, the diagnosis of PTSD is not applicable. Um, does everyone agree with that? All right. So he doesn't meet the full criteria of PTSD, but it's a possibility, and it's something that needs to be um, further uh, further elucidated or investigated. Um, let's go on to antisocial personality disorder as a differential. This patient has been incarcerated repeatedly. He does not report. He does report being impulsive. He reports persistent irritability and a history of repeated physical fights. He described a long history of not functioning well academically in school, which contributed to his truancy. In spite of meeting most of the criteria for antisocial personality disorder, he does not seem to exhibit any deceitfulness or manipulative behavior, which are key factors for this diagnosis. Therefore, the diagnosis of antisocial personality disorder will only be considered as a differential and as a differential and not a true diagnosis. Uh, does everyone agree with that?
Yes, Dr. Russell.
Yes.
Yeah,
Yes.
yeah, yeah. He doesn't seem to be a malign or manipulative individual. He's almost at the mercy of his brain just being on fire, and but he's not contrived or sociopathic in any way. Let's go on to the next differential, which is unspecified attention deficit hyperactivity disorder. The patient described problems academically throughout his education. He currently exhibits some distractibility as he's often looking around at the clock or behind him when there's a noise in the clinic. He's not able to subtract serial threes from 100. There's insufficient information to make a diagnosis of ADHD. Uh, but once his mood is stable, he should be reevaluated. Um, does everyone agree with that? I mean, he has some distractibility, attentional problems, but it may be related to this mood instability. Um, and that once we get that under wraps, under control, he may have some residual concentration and attentional problems, which may constitute an ADHD diagnosis. Um, does everyone agree with that assessment? Yeah,
Yes.
exactly. All right.
Yes.
The additional differential is mild neurocognitive disorder due to TBI. Uh, although the patient reports a history of multiple concussions from fighting over the years, it is not known if he experienced any loss of consciousness, post traumatic amnesia, disorientation, and confusion, or any neurologic signs. Therefore, the diagnosis of mild neurocognitive disorder due to traumatic brain injury is not applicable without any additional information. So, yeah, this guy obviously has been in a lot of fights, physical altercations, and physical abuse from his dad, but it didn't meet the criteria for TBI, so it's hard to um, make a diagnosis at this point of cognitive disorder. Um, more information needs to be assessed, and he needs to be monitored more to see if he has any true cognitive issues. Does everyone agree with that assessment?
Yes.
Yeah, that wouldn't be very high on my differential. Now here
Okay.
comes the one that is high on my differential, which is, and you know, I would consider him having it. It's intermittent explosive disorder. It's not a very popular diagnosis, and I don't know if any of y'all have used it or heard of it before. Um, but this differential diagnosis is included because it describes impulsivity, rage, irritability, and a history of physical fights and arguments that the patient has experienced. However, the patient's rage is constant rather than intermittent. with a rapid onset with no prodromal period. Therefore, the diagnosis of intermittent explosive disorder would not be applicable. So, um, the only thing that kind of dissuades it is the fact that he has a constant moodiness and irritability, and it's not intermittent, meaning he doesn't have normal periods and then he jumps up. So, jumps into being aggressive. So, and because of that reasoning, I'm thinking he may have an underlying mood disorder, um, um, major depressive disorder or persistent depressive disorder. But, the only thing uncharacteristic about that diagnosis is all the fighting that he does, which is, I guess, but I mean, people could be depressed or they could have a bipolar disorder where, it presents as a lot of physically aggressive and assaultive behavior. But I would say that that's on the outer ranges of those diagnoses typically. So does everyone um, feel okay with the assessment that he doesn't have intermittent explosive disorder? I kind of still think he does, but you know, um,
Dr.
there
Brown,
are.
I don't see a lot of adults being diagnosed with intermittent explosive disorder. Is there a reason why? I don't see that a lot for adults.
Yeah, and it should be seen. I mean, when I was training, I saw a lot of people like that who would just. It's almost like like it was like a epileptiform or seizure disorder. They would be okay, but just all of a sudden, they would just, and it's not a psychosis, but they just get angry and hostile to the point where they fight. And there was no memory loss for the event. I mean, um, but I think this disorder may exist, but people may end up couching it under major depressive disorder or bipolar. You know, kind
Or
of
is
like
it
how
that
those
a
guys.
lot of people don't talk about it when they're, or are we not screening for it more when we do see people?
Yeah, I mean that could be it too. People may not know that this diagnosis actually exists, and just like all the differentials I mentioned, it may get diagnosed as PTSD or antisocial personality disorder or MDD or ADHD, with hyperactive type. So yeah, I think we just don't talk enough about this diagnosis to where it's utilized. But when I was training, we saw a lot of people like this, and we used the diagnosis a lot. Particularly, it was young adults, older adolescents, where we'd see it. You know, um, people that were just apparently normal, didn't really have much of a childhood psychiatric history, but then they would just have these episodes. Um, but it's an interesting diagnosis, and I think it's this. I think it still exists, but we just don't know enough about it. And now people are using more substances, drugs. So I mean, all of these things, all of the behaviors that occur here could be assigned to uh, a whole multitude of other diagnoses that are out there, and it's just not teased out. Um, any more comments about intermittent explosive disorder as a differential?
No.
All right. So, what tests or tools should be considered to help identify the correct diagnosis? All right. We have the Adverse Childhood Experiences Questionnaire, and this is a screening tool that was used for an ACE study conducted by Kaiser Permanente in the 1990s. Um, this study assessed the prevalence of adverse childhood events found to correlate with multiple health risk in adults, leading um, to potential early demise. And I'll go over some of these. I'll go over this questionnaire at the end of the discussion. There's also the standard assessment of personality, um, abbreviated scale. This is an 8 item screening interview for personality disorders. The scale aims to produce a dimensional score that over a certain number is correlated to having a personality disorder. This scale has a utility for the purpose of a valid and reliable way to establish the likelihood of a personality disorder. However, it has multiple limitations, including that it does not indicate a specific personality disorder. So it could diagnose a PD, but it doesn't tell you exactly which one it may be. And there are multiple other diagnostic strategies that may help to understand brain functioning of this patient, um, and a more thorough understanding of the patient's brain development over time. However, these tests, such as functional magnetic resonance imaging and neurotransmitter genetic testing, may have little utility in the medication management choices here, and and the big reason is that functional MRI and genetic um, neurotransmitter genetic testing would definitely not be available in the jail. An important part of the diagnostic process that is unfortunately lacking in jail settings is the ability to collect collateral data from family members and friends. Without this information, there's significant missing data that may otherwise be helpful in establishing a more firm picture of the patient in which to form a diagnosis. So, does everybody agree with the testing or tools that are required to help make this diagnosis? And
Yes.
yeah, the author has a good point. The fact that the person's in jail, we don't have access to any of his historical records. We can't get any collateral information from family or friends. So we're quite limited here. All right, let's go on to formulating the treatment strategy for this patient. Question: what treatment would you prescribe, and what is the rationale? All right. Psychopharmacology. Let's start there. The author states valproic acid, extended release 500 milligrams liquid nightly and titrate to 1,000 POQHS if tolerated. The problem I have with this is that I've never heard of an extended release that came in liquid form. So I think the author here is making a mistake. Um, um, but I do agree with the valproic acid, and they're assuming that valproic acid liquid comes in extended form. Like I said, that's I don't think that's reality. But if you're going to use valproic acid liquid, you got to give it at least TID. It has a very short half life. If you give it once a day, it's not going to stay on board enough to really have a clinical effect. Um, but it does make sense that they have it in the jail because it's cheap and it's a liquid, and you can make somebody drink after you give them the medicine and make sure that they take it and they're not cheeking it or spitting it out or saving it. Um, um, it goes on to state that the patient is exhibiting mood instability. He exhibits significant symptoms of agitation, irritability, and aggression. Valproic acid is a mood stabilizer that the Food and Drug Administration approved for mania and mixed mania. Valproic acid is a good choice as it couldn't be dispensed as a liquid and can be monitored through blood testing. This is an important issue in a jail environment where patients may trade, cheek, or save their medications in their cheeks in order to spit it out later and use it at a later time, or to give it away, or otherwise misuse the medication. Um, it has not been found to give patients a high feeling, such as Buspar or Seroquel or Wellbutrin. Therefore, there's less likelihood of abusing the medication or having it requested by patients in the hopes of getting high or having a sedative effect. So, do people agree with the use of valproic acid, which in pill form is actually Depakote, which can be given in an extended release formulation? But does everybody agree with starting off with the mood stabilizer, valproic acid in this patient?
In a real world, Dr. Brown, would this patient actually be able to get the blood test done to check levels while incarcerated? Or would you pick something else?
Yeah, and that's another consideration. You would hope so, but not all jails are equipped with labs. And even if they did, I mean, they may be so overwhelmed um,
Right?
that the time you
That's
get the
fine with
lab to
me.
the time you get the result, the
Right?
patient could be discharged or
Right.
processed out. So, the utility of that. What I do with valproic acid, I know I just make the assumption that under 1,000, um, they're not gonna they shouldn't go over 100, which is
Hmm.
the level. So I try to stay between 500, and I see how they do, and then I may go up to 750, or I may go up to 1,000
Hmm.
milligrams a day in divided doses, and I just season the taste, and I look for some of the side effects. But the main one would be, gastric irritation, um, dizziness, nausea, and vomiting. Or
Hmm.
something, anything that would affect the liver. Are there any other
Gotcha.
medications? Well, since you're asking, what would you want to try? What would be an agent that
I
you would
would
start off
probably,
with?
I would probably give him like risperidone. If I kind of thought about if the blood's not going to be able to get, back in a timely manner, I would probably give him probably risperidone or something like that for
Hmm.
that those symptoms of the fighting irritability.
Yeah, and the good thing about the risperidone is it does come liquid too, and you could
Hmm.
avoid all the cheeking. My thought, because I'm still stuck on this intermittent explosive disorder, even though it's not really intermittent, but to give him lithium, which is cheap. It does require levels, but once again, I'd keep it below the radar, and it
Hmm.
does come liquid. Um, and just give him a little lithium to see if that works. And if I really considered that he had major depressive disorder without real mania, you could put him back on an SSRI. Try another one, and
Hmm.
then give the lithium on top of that, because lithium actually can help improve depression in people who have MDD. If you can
Right.
augment the SSRI with lithium. So that was
Hmm.
another one of the things I would consider. If he was going to be in incarcerated for a longer period of time and we can monitor it, that's one of the other things that I would consider treating him with. Um,
Okay.
Would you
but
think of lithium subtherapeutically, like below the therapeutic levels with that SSRI for his mood?
yeah, I mean, you probably have to get to a therapeutic level, but once again, you got to season the taste. To me, anywhere between 600 to 900, you're kind of in a therapeutic range. Some people may require 1,200, but he's this guy's a time bomb in a situation where there's probably a lot of other people just like him, and the COs don't have time to break up fights, and somebody may end up getting killed. So I would just risk, you know, putting him on the lithium and just seeing how he does, subtherapeutic, and slowly getting it up to where he's under control. And once again, season the taste as best I can. But lithium is a drug. It's not to be played with. And I like it because it's an old gold standard. It's something that I use a lot when in my training. We saw it really, really work. But you gotta do those lab tests. You gotta check the thyroids. You got to make sure the person has good kidney functions. It's not metabolized by the liver, so you don't have to worry about that. But you still got to monitor it. But I generally, in situations where I know if I don't do anything, I'll usually take these medicines and try to just use them subtherapeutic to see if I'm getting some response, and then I may jump up to a level where I know I'm fairly safe, and then I'll make every attempt to try to get the lab work as best I can. Just to try to keep things calm, and just see them frequently. You know, ask them about side effects and adverse effects. Does that answer your question?
Yes, thank you.
All right. Now let's go on to diagnostic tests for this, and this is in specifically for the valproic acid. Conduct a baseline labs including recent liver functions, complete blood count with diff and electrolytes. So that's baseline, and then after 4 to 6 days of the valproic acid, um, order valproic acid level, reorder your LFT, CBC with diff. And then after 25 to 35 days of medication continuation, reorder your LFTs, CBC, platelets, and valproic acid level. And then thereafter, you repeat every 3 months. So you always want to get a baseline if you can, you know, and then a week after initiation, um, do a repeat, and then 30 days. And once again, in a jail system, that is, I don't know where they're located, but you know, um, it's unlikely that you're going to be able to get this many blood draws on one person if you can get it at all. Um,
Exactly.
yeah, and they say the therapeutic range of Depakote is 50 to 100. Over 100, the patient may have symptoms of toxicity such as tachycardia, hypotension, cardiac arrest, coma, confusion, irritability, hallucinations, ataxia, and even cerebral edema. Blood pressure, weight, and heart rate are to be monitored at each visit. And if necessary, you can monitor blood glucose levels and A1C. Um, and I normally, we've seen, you can, the lithium level can be between 50 to 150, but at 100 you start getting concerned. But some some labs, the cutoff is 100. Some labs, the cutoff is actually 150. So any questions about these diagnostic tests, other than the fact that the author here may be a little bit delusional themselves and thinking they can get all this stuff in a criminal justice setting, in a jail setting. All right, we'll go to referrals. None are indicated at this time. The type of psychotherapy, therapy in the jail and out of the jail once released should include trauma-informed group therapy, substance abuse treatment groups, personal therapy with such as cognitive behavioral therapy, meditation, and other stress reduction practices are also recommended. Psychoeducation, the patient experiences anger toward the correctional officers as well as the other inmates for baiting him into fights. He reports an inability to relax, and he usually gets into fights during these times of agitation. Um, Going to the cell during to these times to separate from others and practice mindfulness is recommended. Focusing on his breathing, counting backwards from 10 with deep breaths, and listening to his inhalations and exhalations are recommended. Uh, Education about the effects of childhood trauma and how it is highly correlated to many of the symptoms he is experiencing, such as alcohol abuse and repeated carcerations, should be provided. Relaying information in a trauma informed framework may help the patient gain some insight and make the connections between his past experiences and his present dysfunction. Um, Anybody have any issues with psychotherapy, psychoeducation recommendations? All right. So here's a clinical note. some caveats. Adverse childhood experiences may result in consistent stress on the brain that can, over time, alter the brain as well as other important processes in brain related growth and development. Jails are an appropriate place to screen patients for childhood trauma because jails are often the first place that these patients struggling with or these patients struggling with mental and substance abuse are seen by a psychiatric provider. And we all know that jails are probably the largest deliver psychiatric services probably in the country. Um, that's where most everybody gets. That's where most everybody gets their psychiatric care in the jail and prison system. Screening for trauma is important in order to initiate therapy, uh, and if needed, medication management. Um, Many patients in jails consider themselves black sheep or victims of the system. To avoid this cycle of recidivism that is so prevalent in our country, mental health screening and treatment are an essential part of the rehabilitation process that is so often missing in our jails and prisons. And then the ACE score, which is the Adverse Childhood Experiences score of 4 or more, may actually indicate a significant risk of medical and additional psychiatric disorders. So I've never heard of the Adverse Childhood Experience scale or questionnaire, but if it's valid, it may be a good tool to use to determine if if someone has had enough traumatic experiences as a child where it should be formally addressed and treated. Here are some, and it's a 10 question scale. I'm going to just read through all 10 questions real quick just to give you an idea what the questionnaire looks like or sounds like. Question one: did a parent or other adult in the household ever swear at you, insult you, or put you down or humiliate you? Question two: did a parent or other adult in the household often push, grab, or slap or throw something at you? Question three: did an adult or person at least 5 years older than you ever touch or fondle you in a sexual way? Question number four: do you often feel that no one in your family loved or thought of you as important or special?
Exceptional mental health. This is Valencia. My help.
Question number five: Uh, did you often feel that you didn't have enough to eat or had to wear dirty clothes or there was no one there to protect you? Question number six: were your parents ever separated or divorced? Question number seven: was your mother or stepmother ever pushed or often pushed, grabbed, slapped, or had something thrown at them? Question number eight: did you live with anyone who was a problem drinker or alcoholic, or who used street drugs? Question number nine: was a household member depressed or mentally ill, or did a household member ever attempt suicide? And question number 10: did a household member ever go to prison? So those are the questions on the on the adverse childhood experience questionnaire. Okay. Any questions?
Dr. Brown, I have a question about that questionnaire. Sorry, is what makes it positive? How many out of the 10?
Four.
Okay.
Yeah. If you have four, which is low, I mean, but if you have four out of those 10, you may have some significant issues that need
Right.
to be addressed. Now, I'm gonna um I'm gonna switch over since we were talking about intermittent explosive disorder. I'm gonna go over a quick case study with some questions related to that. We got a 22-year-old male who comes to your clinic after his boss told him he would need to seek help to keep his job. The patient reports he works in a warehouse. Over the last few years, he has been involved in several verbal arguments with coworkers and previously at school. Uh, he says people will make comments sometimes about him that he finds offensive and it sets him off. More recently at work, he has kicked a trash can and punched a shelving unit. One of his coworkers also made a comment and he pushed the coworker into a wall. Outside of these moments of anger, the patient reports his mood is mostly okay and he denies any regular extended period of irritability. So that separates him from the other guy who said his irritability was ongoing. This patient denies any pre-formulated thoughts now or previously of wanting to hurt others. So he has normal functioning and then he has these episodes. This is what distinguishes intermittent explosive disorder from bipolar or PTSD or major depressive disorder. So, what is the most likely diagnosis here? ADHD, antisocial personality disorder, intermittent explosive disorder, or bipolar. I already gave you the answer.
Right.
So it's intermittent explosive disorder. Based upon your answer for question one, what is the 1 year prevalence of this disorder in the United States? Approximately 3%, approximately 6%, approximately 15%, approximately 20%.
Say 3%.
The answer is 3%. Yep. Um, Question three: what areas of the brain have shown changes in patients with this disorder? We got the limbic system and orbital frontal cortex, which is right above the eyes. We got the limbic system and the parietal lobes. The parietal lobes are right above the ears. And we got the limbic system and the occipital lobes, which is in the back of the head, are none of the above. Which part of the brain do you think is affected? What lobes control executive function and management of our feelings at an
Oh,
executive level? It's yes, the frontal
frontal.
lobes. Yeah, so it'll be the limbic system and the orbital frontal cortex that are not functioning well, and he can't control his impulses, you know, and so he's unfiltered. Um, Question number four: what treatments are used to treat disorder in adults? We got A, CBT, B, mood stabilizers, C, uh, SSRIs and SNRIs, or D, all of the above. What do y'all think? CBT, mood stabilizers, SSRIs, SNRIs, or all of them?
All of the
All of
Which
above.
them.
all of them, exactly right. Everybody scored 100. Okay, y'all are cooking with fire. All right. So does anybody have any questions about this case or the differentials or the treatments, how to make the diagnosis, um, anything?
I want to know if I want to know what you would pick if, well, all of the meds that you would consider if Depakote wasn't an option. You said lithium. What else would you
Oh,
pick?
like one person
What list?
mentioned risperidol, but
Mhm.
I may or may not do that because once they get on it, then someone's gonna think they have a psychotic disorder, and they may not. So I try to stay within the mood stabilizer class, but I like Lamictal. Lamictal, I use it in a lot of kids who have mood
Mm.
dysregulation disorder. So I'd probably put them on a little bit of Lamictal. There's also Tegretol, which is an older drug, but still you got to measure the levels. And oxycarbamazepine, which is a variant of Tegretol. Keppra, I hadn't been impressed with Keppra as a mood stabilizer. What else? Those are yeah. I usually my go-to is going to be valproic acid slash Depakote and Lamictal, and you definitely want to avoid any of the benzos, even though people think they calm people down. They could disinhibit somebody like this and make them worse. Um, but yeah, um,
Thank you.
Lamictal, yeah, Lamictal, Tegretol, Depakote. Um, some people may end up using things like gabapentin and all of that, but I don't. I think the real hardcore ones are those. And then, if I could, I would use, if I felt comfortable with the medical staff and them and him being able to get on the schedule, I'd really consider lithium, to really get him under control quick. So all that fighting and moodiness and anger and could really get under control. And lithium works probably within 7 days. It'll start creating some changes in the neurons to where we could see some improvement in his functioning. And I do that with a SSRI. I may not use the Prozac because it may have bounced him up too quick, but I'd probably try a little Lexapro or Zoloft, with
Okay.
that. All right. Any other questions
Thank you,
about
Dr.
this?
Brown.
Oh yeah.
No,
Any other questions about this
Thank you,
case?
Dr. Brown.
All
no,
right. I know y'all got to go.
no
You
questions.
got to get to work. All right then.
No
Thank you.
questions. Thank you.
All right then. We'll have another case next month. Okay.
All right. Thank you.
All right. Bye bye.
Thank
Bye
you.
bye.